Hello everyone, my name is Lydia Hellewell and I am a plastic hand and reconstructive surgeon at Brigham Women's Hospital in Boston, also an assistant professor of surgery at Harvard Medical School and the co-director of lower extremity reconstruction. Today we're going to discuss soft tissue coverage in the lower extremity in the setting of trauma, focusing especially on practical approaches to skin grafts and pedicle flaps. Recognizing that the audience for this talk will largely be orthopedic surgeons, we're not going to dive into bony management, as you all are the experts of that. And we're going to try and be very practical about soft tissue recon in case you are in situations where you are doing these procedures with no assistance from plastic surgery. I have no disclosures. So here's an outline of what we're briefly going to touch on today. We're going to talk about general principles of lower extremity soft tissue reconstruction. And we'll also talk about the reconstructive ladder and then dive into some options. So when we talk about lower extremity trauma, we'll mostly be focusing on bony injuries that additionally involve a large soft tissue deficit. Initial management includes collecting all the data you're going to need before attempting any reconstruction. As a plastic surgeon, I'm most interested in what was the mechanism of injury. Was it a motor vehicle accident, a farming injury? This is going to determine your level of contamination. I also want to know what the fracture type is. Has it been reduced? How is it going to be stabilized? What the soft tissue status is. Has it been debrided? Is there a lot of threatened tissue? Obviously, the neurovascular status. Is there a known nerve or arterial injury? And then finally, obviously, you'll have plain films, but if you can get a CT and a CT angiogram, those can be very helpful for planning your reconstruction. Next, the physical exam is obviously key. As a plastic surgeon, I'm focused on what is the appearance of soft tissues, what have we lost, what looks threatened. I want to know if there are any exposed critical structures, and then a thorough pulse, sensory, and motor exam, if possible, are critical. And then I want to know what's the fracture pattern, is there bony loss, how are we going to treat it. Usually, initial interventions are prompt antibiotics, tetanus shot, and then reduction in the ED. The patient is then splinted, and then hopefully they're going to the OR for washout, debridement, and fixation fairly quickly. Debridement, it's key. In our practice, we will take them to the OR, do our initial stabilization, debridement, place a vac, and then go back to the OR every 24 to 72 hours for repeat debridements until we think the wound is stabilized and is ready for coverage. Ideally, coverage is done as soon as possible and as either at the same time or as closely related to the final bony stabilization. But if you cover without doing proper debridement, it's likely going to leave you with inadequate coverage and potentially infection, osteomyelitis, and non-union. Scott Levin wrote in this paper cited here that, quote, "When the debridement is complete, the wound should ideally look like the site of an operative tumor extirpation." And I think this is really important. Obviously, you don't want to be too aggressive and debride tissues that would ultimately survive. But again, if debridement's not adequate, your reconstruction is ultimately going to fail. In plastic surgery, we talk about the reconstructive ladder. And it's a way, this has more recently morphed into the reconstructive elevator. The idea being that you approach a wound, the reconstructive ladder, you sort of go from simplest to more complex. The elevator, you jump to whatever you think is most appropriate, depending on the wound you're dealing with, and not just choose the simplest. But either way, you're kind of thinking about different options. Today, we're going to focus on skin graft and local tissue transfer options. We're not going to talk about free flaps, although many of the complex injuries you're going to see today could have been addressed, although they were addressed with local options, could have been addressed with free tissue transfer. So I'm going to start with skin grafting. Here, first, we're talking about full thickness skin grafting. As you can see, I'm using a full thickness skin graft to the face because I haven't actually ever used a full thickness skin graft to the lower extremity. Usually we're opting for a split thickness skin graft, but if you need to do a full thickness skin graft for whatever reason, you harvest them from creases where you can close it primarily. You harvest the full thickness of the skin, and then what's really crucial is that you defat that skin graft with scissors. You want basically no fat left on that, which will increase your rate of take. And then the wound bed obviously needs to be clean, well vascularized, free of infection. As you can see on the right here, we're doing a tie over bolster for this, which you could do on the lower extremity as well. A split thickness graft utilizes only a portion of the skin, obviously leaving some dermis intact. We do this much more commonly for the lower extremity. In our center, we use a Zimmer dermatome shown on the left. The plates there on the right, and there is one plate already on it, determine the width of the graft, and the width you decide by how much skin you need. Anterolateral thigh is our most common donor site. The Zimmer dermatome allows you to choose the depth of your, or the thickness of your skin graft, and you use that black dial shown on the lower right there to help you decide that. Usually we do 12 to 14 thousandths of an inch, but you might choose thinner or thicker depending on both the patient's skin on their donor site as well as what wound you're trying to reconstruct. But 12 to 14 thousandths is usually a pretty good place to start. We usually put a Vaseline gauze sutured over the donor site, and we cover that with a Tegaderm and Telfa, and then after 2 days we remove that and allow it to dry out, and eventually it falls off as a scab. At the time we harvest our skin graft, we always use some sort of epinephrine solution combined with local or not. The donor site can be incredibly bloody in this, so it's important to do that. We mesh our skin grafts most often. This helps get for fluid egress that would otherwise accumulate under the graft. It also allows you to harvest a smaller graft that can be spread out over a wound. We do that with what's called a Brennan mesher, shown here on the bottom left. But in the skin graft example here, I chose this one because our meshers, I forget what happened, but it basically stopped working about 2/3 of the way through. So the distal 2/3 of this graft are meshed with a Brennan mesher, and then the proximal 1/3 is meshed just with stab incisions from a 15 blade. But you can see it went on to heal totally fine. Over the skin graft, you're going to need some sort of bolster to prevent fluid buildup and also prevent shear. We most often use a vac to do this, a vac dressing, but you can do a tie over bolster, and both of those will accomplish that goal. Vacs are just a little easier to get over concave surfaces. Split thickness skin grafts are ideally harvested from sort of broad, flat surfaces. Full thickness skin grafts are usually harvested from creases, and obviously you can get a lot less. The lower abdomen is a place where you can ultimately get the most from. But either way, when you do a full thickness skin graft, you really have to make sure you defat it well. So now we're going to turn our attention to lower extremity soft tissue flap reconstruction. This article from PRS Go, published in 2020, does a really nice job of summarizing different options. On the right most column, they talked about the preferred flap, but honestly, I think the traditional flaps are still the workhorse for most surgeons performing lower extremity, as propeller flaps and free flaps certainly require a higher level of resources and surgical experience. If you're in a situation where you do not have the help of plastic surgery, then knowing how to perform a gastrocnemius for knee and proximal third, a Soleus flap for mid-tibial, and either a reverse sural flap or some sort of propeller flap will get you through most of your reconstructive soft tissue defects as long as they're underneath a certain size. But if your center has the colleagues and the capability to perform free flaps, these can be great options for any of the wounds we're going to discuss today. Or some of the wounds. So let's dive into some examples. Here's a 42-year-old male. He sustained a complex distal femur and proximal tibia fracture after a motorcycle accident. You can see he's got lots of different kinds of hardware in there. And importantly, he clearly did not have an adequate debridement done. So without intervening, he's at really high risk for having exposure to the hardware and later infection. So we brought him to the operating room for aggressive debridement. And that resulting wound is shown here. Proximal third of the lower leg with exposed bone, fracture, and hardware. And this location is ideal for a gastrocnemius muscle flap. It's on the larger end of what a gastroc can cover, and in some places a free flap may have been utilized for this. But this man was healthy, young, had muscular calves, and the gastrocnemius muscle did cover all the critical important structures that were exposed. The medial gastrocnemius flap is harvested through a medial incision, as shown here. You're going to raise a plane superficial to the muscle, between the muscle and the skin and fascia, clipping any or cauterizing any perforators. And then you're going to do the same between the gastroc and the soleus. The plantaris tendon can help you identify this plane, which is especially important if the wound is traumatized. It can be possible to get lost. And then once you've dissected both planes, you're going to identify the raphe between the medial and lateral gastroc muscles. And then you're going to separate the medial gastroc from its insertion into the Achilles, and then start to elevate it, carefully separating it from the lateral gastrocnemius muscle along the raphe. And you're going to do this as proximally as possible to allow you to rotate the muscle into the wound. And you're going to clip perforators along the way because the main blood supply to this flap is coming proximally as the medial sural artery. You can tunnel it, but in this case, obviously, our wound and our donor site are connected, so we were just able to rotate it in. And what you can't appreciate, except on a little bit on the photo all the way to the left, is that we've scored the fascia, which allows the muscle to reach further and spread out wider. And I do this with a 15 blade, just going right through the fascia, but not into the muscle, because especially on the deep surface of the muscle, the pedicle runs on that side. So if you go too deep, you can injure the pedicle, especially more proximally. This is a smaller wound, but how you might design your incision. You can place the incision a lot of places, but honestly, this is where I like to do it. It's about 2 finger breadths or so behind the tibia on the medial side. I curve it towards the wound more proximally. I don't always make it this long, but I like to curve it towards the wound just in case I need to connect them or I don't want to tunnel because the tunnel's too tight. It does make your proximal dissection a little more difficult, but this is how I like to do it. These are great illustrations from Netter and from Dr. Milliken's plastic surgery textbook. I think the anatomy for the medial gastroc flap is relatively straightforward, and we've discussed some landmarks that can be helpful, such as the plantaris tendon, and the sural nerve actually is located at the raphe, so those 2 things can help you in your dissection, and that's especially important in a traumatized limb where the planes are not, at least initially, really easily identified. Again, the medial gastrocnemius muscle is supplied from the medial sural artery, so all the more proximal perforators are going to clip, and it allows you to elevate the muscle very proximally and get rotation up to the knee. So now we're back to our initial patient. Muscle flaps in place, skin graft underneath. We put a vac over this, but you could just put a Vaseline gauze dressing. And then here he is several months later, he completely healed. Here's another example of a gastrocnemius flap in a trauma setting. This patient, in addition to having a complex tibial fracture from motorcycle accident, had a pretty significant bony loss. And you can see that antibiotic spacer that was placed both in the plain film and then at the base of the wound on the right. And our planned harvest incision is here on the medial calf. On the left, you can see the gastrocnemius muscle, the planes, both superior and deep to it, have been dissected out. That arrow is pointing to the plantaris tendon, which again can help you ensure that you're in the right plane. Has not been divided distally. And then on the right side, we've divided it both from the Achilles and then done the raphe and then scored the fascia with a 15 blade. And then we're going to tunnel it into the wound. Here it is covering our wound and with a skin graft over the top. And you definitely want to ensure you get careful hemostasis because there are a lot of perforators coming through the medial gastroc muscle and it's a big donor site. So you're going to place drains both to the donor and the recipient site if possible. This is him fully healed on the right, and we did actually bring him back a couple months later for elevation of the flap, removal of the spacer, and bone grafting. And as long as you know where the flap is coming from, in this case, if it's a medial, you're starting lateral and elevating, the flap can be easily elevated and reclosed. Here I'm showing a lateral gastrocnemius flap. Now these are used much less commonly because the lateral gastroc head and muscle belly is much smaller and you have to worry about the common perineal nerve. But if your wound is small and more lateral, the lateral gastroc muscle is certainly okay to use. You can see we've scored the fascia here on the left, and then on the right it shows it rotated into place. Again, you got to watch out for that common perineal nerve, so it limits how much you can dissect the flap proximally, and so it's not as good for knee wounds and better for a little more distal along your tibia. And then here we have it covered with skin graft, and you can see the donor site for the skin graft on the lateral thigh. And then here she is healed several weeks later. Now we're going to turn our attention to the soleus muscle flap, which is often harvested as hemisoleus. It's most useful for mid-tibial defects. So unfortunately, in most complex lower extremity trauma, the zone of injury can be quite significant, and the soleus flap, given its deeper location, closer proximity to the tibia, can be involved with the injury, and therefore elevation can be difficult, which can put the posterior tibial vessels at risk. It can also be unreliable as a result. However, in the right patient, it can solve a complex mid-tibial open fracture, as long as the soft tissue defect is relatively small. It is supplied by perforators from the posterior tibial artery. It's located between the gastrocnemius muscle and then the deep posterior compartment. Like harvesting the gastrocnemius muscle, you have to develop the planes both above and below the soleus flap, and the distal perforators of the posterior tibial artery are clipped, but you have to maintain the more proximal perforators because that is what the blood supply to the muscle is, and this obviously limits your rotation ability. The plantaris tendon can help you identify the plane between the gastroc and the soleus, and then you have to be careful about the posterior tibial vessels because they're just underneath the soleus and can be injured. The medial raphe is identified sort of where the fibers are coming together in this sort of V-shaped formation, and you divide the medial from the lateral half and rotate it into place. We've on the right side, you can see we've got our muscle flap sort of elevated up, and then on the left side, we're rotating it into position over the fracture, and you can see we've scored the fascia once again. Unlike the medial gastroc flap, which has one large pedicle in the form of the medial sural artery and vein, the hemisoleus muscle flap is supplied by a number of perforators, which are coming from the posterior tibial artery. So in this picture, as on the left, you can see they've divided the distal perforators, but they are maintaining the proximal perforators. And you need to maintain those in order to maintain your blood supply. It also limits your dissection, so you can't rotate it as much as you would like, and thus why it's only really good for mid-tibial defects. So here's our hemisoleus flap in place, and then with a skin graft over the top. This patient was actually, because of a number of comorbidities, was treated definitively with this X-fix. And thankfully she did go on to heal. And there's her with her X-fix removed. In certain situations, you can combine a gastroc and a hemisoleus. This patient initially, here he is on the left with his X-fix in place, and then the hardware was transitioned to internal fixation. However, obviously he had a large defect, and he was not a candidate for a free flap, which I think a lot of people would have done in this situation. So he got a combined medial gastroc hemisoleus, and you can see our hemisoleus more distally, and then the medial gastroc with its fascia incised there, both rotated in place with a skin graft over top. Obviously, this is pretty morbid for the leg, which is why a lot of people would have done a free tissue transfer, but that was not an option for this patient. And here he is fully healed with bony union. Now, more distal third wounds of the ankle and the foot can be quite difficult in settings where free tissue transfer is not possible. The reverse sural flap has been described for these wounds and has been used successfully in many situations. In my practice, my first choice for these wounds is free tissue transfer, but in certain patients who can't undergo microsurgical reconstruction for whatever reason, I have done reverse sural flaps. This is an example of such a patient: lateral wound, exposed bone and tendons, not a candidate for a free flap. We've Dopplered out our sural artery pedicle here, divided it distally, which is that picture on the right. And I'm actually, in this case, doing a delay. I like to delay this flap if at all possible because I think it increases its reliability, especially because I'm often doing this in a patient with a number of comorbidities. They're elderly, diabetic, peripheral vascular disease, whatever the reason they're having the flap, it's often because they can't have free tissue transfer. I also leave a skin bridge to aid in venous drainage, as I think inadequate venous drainage is the cause of loss of the distal portion of this flap, which is often the most important. So you can see we've elevated, or at least partially, the flap, divided the pedicle, and then we sutured it back into place and then came back a couple weeks later to inset it. The upside of this, we've skin grafted the donor site. The upside, you have a reliable coverage. The downside is you have this huge dog ear, and that can be really prominent and annoying for patients, limit the kind of footwear they can use, but you can come back once everything is healed several months later, divide that skin bridge, and remove that dog ear. This is a similar patient, lateral malleolus wound, exposed fracture and hardware. Again, I did a delayed reverse sural, which in this case was a good idea because, as you can see on the right there, the distal portion of the flap did necrose. And here it is inset with a skin graft to our donor site. Again, because this patient he still has a dog ear, he's thinner, so it's a little less prominent. And here he is healed, and he actually did not come back for a revision, which you could certainly do. Again, in my practice, I would probably do free tissue transfer for a lot of these wounds in healthier patients, but for whatever reason, these patients were not candidates, so they got a reverse sural and a delayed one with a skin bridge at that. I think if you are doing this in a setting where you have healthy patients with a limited zone of injury, delay and skin bridge may not be necessary. Propeller flaps are another option for patients who have distal wounds that can't have free tissue transfer. I actually think propeller flaps can be just as difficult, if not more difficult, than free tissue transfer because they're being designed within the zone of injury, and you have to completely dissect out the perforator, which is just as difficult as harvesting a free flap. And I think when you read about these, you often see more drawings than clinical photos, which I think hints to their lack of utilization. But this is a patient, 87, bad fracture, and she was demented, had lots of comorbidities, but we really wanted to salvage her extremity because an amputation would have really resulted in loss of her independence. So orthopedic trauma surgery internalized her hardware. Here's her wound after debridement. We designed our flap based on this perforator that we Dopplered out and have an X on right there. You literally fully incise and elevate this entire skin paddle just based on that perforator alone. You have to completely skeletonize it, and then we rotated it 180 into the wound and then did a skin graft behind. And she ultimately went on to heal, including her bony injury, and she was able to avoid amputation. This is another example of a small sort of perforator rotation flap. Again, a lot of people would have chosen a free flap for this, but she wanted to avoid that. The small X on the right is where our perforator is. I think in retrospect, I would have designed this a little bit bigger, or a little longer, I should say. But we got it to work. Everything healed. Flap survived, and she looks great. I will add that most of these pedicled flaps for the distal third, as you can see, the wounds are relatively small. You can't use these for really big wounds. They just aren't big enough. So if you have a really big distal wound, you really are limited to free tissue transfer or, in the right situation, a cross leg flap. Finally, I want to touch on a couple postoperative considerations. So immobilization of these fractures may not be necessary if they've been definitively treated with internal stable hardware. However, if the patient is bedbound for any reason while you're, doing debridements or getting them healed, you really want to watch out for Achilles contractures. So you're going to use a 90-degree ankle splint. If you do something like a gastroc or even a soleus muscle flap, you might consider a knee brace because if they really flex their knee, you could avulse the gastroc flap. Obviously, you want to watch out for pressure from these splints and braces. Antibiotic course is usually determined by cultures from your final debridement. That can, if those come back positive, they can be on antibiotics, either IV or oral, for as long as 6 weeks. We let ID, our infectious disease team here, help us with those decisions, thankfully. And then finally, although boning healing often dictates weight-bearing status in these situations, if these flaps can become really edematous and it can affect their healing, you can get venous insufficiency, etc. So if they're not actively walking, I like my patients to elevate their flaps as much as possible, elevate their leg as much as possible, which will help prevent edema, which can be permanent in these flaps. I hope this lecture has given you some ideas for how to get lower extremity coverage via either skin grafting or local pedicle flaps. And I want to thank you for your time today.